In terms of full profiling of the tumor, so genomic sequencing of tumors, we only do those in stage 4 cancer. Stage 2 and stage 3, certainly not, because most of them will never need the information that we get from genomic sequencing. When we do genomics, so next generation genomic sequencing, we want to ensure that we have elements that are important for decision making. So if your practice, does not have access to next generation sequencing, you have to at least have the following on hand: MSI high, so microsatellite status, RAS alteration, so KRAS and RAS, BRAF V600E, as well as HER2 amplification. I think HER2 amplification is now very important, a very important component of how we decide or stratify for treatment options. In addition to that, of course, we have to figure out whether the disease is left and right, and there are another number of other elements that go into the equation to select the best therapy. In our practice, we try to sequence all the patients. And I think the important aspect of this is that we uncover other alterations that may be relevant in terms of choice of therapies or other therapies down the line. So it helps us in planning whether patients could be directed towards gene-directed therapy, molecular target therapy, immune-directed therapy. One example is MSI high, although can relate to tumor mutational burden and to use of immune therapy. There are certain alterations that are less common than Lynch or somatic MSI high, such as POLE, POLD, and CHEK, and others that you will not uncover unless you expand your profile. And for those patients, the tumor mutation burden can be quite high, and they seem to benefit equally from the application of immune therapy. So I think it's important. Now, people go back and forth on, I want to start with a small, panel, just directed panel, and then expand it later on. The reality is these things, most of them don't change much across. There is heterogeneity. We know 10-15% can be heterogeneous intratumorally or between one lesion and the next. But the reality is for most of these alterations, they stay consistent through the lifetime of the tumor. And I think it's important to have all these alterations figured out from the day you essentially see the patient, if possible. At a minimum, MSI, so a microsatellite status, RAS, BRAF, HER2, preferably an expanded sequencing. And then I will add one other element. I think it's very important to try to get RNA-seq when it's available through the platform. There are a couple of platforms that essentially include RNA sequencing with this. And I think they're very important because some of the fusions, such as NTRK fusions, which are important at some point of treating the patients, NTRK fusions, although rare, but can be missed if the platform does not include an RNA-seq. In fact, you may miss up to 30% of these fusions, like NTRK fusions. Again, and we have a drug an agent, I should say, that targets NTRK fusions that's approved to the clinic. So the other element to this is I hear a lot occasionally from physicians, well, why do I need to keep on looking consistently for an MSI high or for an NTRK fusion since they're incredibly rare? Totally understand. However, if you think about it, MSI high is present in 4% of patients, NTRK fusions 0.7%. If you don't check consistently every patient that comes through the door, your 4% becomes 1% and your 0.7% becomes 1 in 10,000, just roughly. So I think that consistency is very important because we want to make sure every patient that gets through the door to our clinic has every option explored for them and placed in the armamentarium sequentially. At some point, we're going to need one or the other depending on their genetic profile.